Now, it is my pleasure to introduce the second webinar. We will be in touch by email to share topics of our future webinar in the series with you. Today's webinar will be given by Drs. Rebecca Ganann, Julie Abelson, and Maggie MacNeil, and with our community partner, Penelope Petrie. Dr. Ganann is a registered nurse and assistant professor in the School of Nursing at McMaster University. She is also a co-scientific director of the Aging Community and Health Research Unit. Through her work with the Ontario Spore Support Unit and the Mira Collaborative for Health and Aging, Dr. Ganann works to advance the science of patient engagement. Her research program is focused on older adult engagement and co-designing community-based health research to promote health, mobility, and well-being in older adults and address health inequities. Dr. Julie Abelson is a professor in the Department of Health Research Methods, Evidence, and Impact, a member and past director of the Center for Health Economics and Policy Analysis, and director of the Health Policy PhD program at McMaster University. She leads the Public and Patient Engagement Collaborative, which carries out research and service activities focused on supporting high-quality public and patient engagement and partnering in health policy, health systems, and health research, with a specific focus on the evaluation of these efforts. Through her research, education, and service activities, Abelson works closely with patient partners, researchers, and health system decision makers in provincial, regional, and local governments. Dr. Maggie MacNeil is a postdoctoral fellow in the Department of Health Research Methods, Evidence, and Impact at McMaster University. Her research interests include health policy, gerontology, health technology adoption, and evaluation of older adult engagement in research. Between 2013 and 2015, Maggie was a policy analyst in the Ministry of State for Senior Support Unit, Employment and Social Development Canada. Maggie's postdoctoral fellowship is focused on evaluating a community co-design initiative with older people and community health and social service providers. Penelope Petrie joined the collaborative in 2019. She's a retired teacher and lifelong learner. Penelope is a volunteer with a number of organizations in Hamilton and McMaster University that focuses on issues impacting older adults. She joined the collaborative because it offers several opportunities to learn about aging research, influence health policy, and promote healthy aging. Penelope's goal is to ensure best practices are being implemented in communities in need. Just give me 1 second. So thank you everybody for joining. The title specifically of the webinar is Engaging and Partnering with Older Adults in Mira Collaborative, Implementation and Evaluation. So just briefly, the session outline for today, and we also have a poll that we'd like you to complete. So I'm just going to launch the poll and it should pop up on your screen and then we can share the results right after that. All right, so in terms of the session outline, we're going to provide an overview of patient-oriented research, patient engagement, and the Mira Collaborative, and Julia will speak to that. Engaging and partnering in the Mira Collaborative will be reviewed by Penelope and Maggie, and then the systematic review on implementation and evaluation of engagement and partnering with older adults in research will be given by Rebecca. So I'm just looking at the poll results. It's been really quick, so thank you everyone for taking the time. Right now we sort of have a third, with researchers, trainees, and others who have joined the poll, a few citizens as well. Most people are from, 95% are from Central Canada, and 40% of people have some experience working with partners on 1 or 2 projects, followed by no experience. And then third ranked would be individuals who have lots of experience. So I hope to be able to share these polls, but at this time, I'm going to turn it over to the speakers. So thank you, everyone.
Great. Thanks very much, Jennifer. So I'm first up. Hi, everyone. Great to be with you. I'm going to be giving hopefully a fairly short overview of patient-oriented research, a little bit of the broader patient engagement landscape, and introduce you to the Mira Collaborative. Next slide, please. So in terms of providing you with a brief overview, I wanted to give you just a sense of the background of patient-oriented research, kind of where it comes from, and really point out, importantly, I think that this is not a new idea. The idea of involving community members, citizens, and patients in health research or health system decision-making. It's not a new idea. There's been a long history of community-based participatory research in the health and social sciences, and many of you on this webinar might be quite familiar with that and have participated for a long period of time in this type of research. It is, however, newer to the biomedical and health systems and policy research communities to some extent. I think what is really important to recognize, and this is how we introduce, the idea of patient-oriented research and the larger strategy for patient-oriented research, or SPORE initiative, is that the investments and the requirements for doing this within the Canadian health research community are much newer, right? And this is kind of the world that many of us are working in now. Next slide, please. Next slide, please. So I often like to talk about different eras in public consultation and public and patient consultation and engagement and partnering. And I think this 2013 cover of the BMJ captures it nicely, the era that we're in. Not only as patient engagement and partnering in health research, a very major focus of activity, but this is actually true across many other sectors within the health system, whether it's quality improvement, planning and policy making, the health technology assessment arena. There's just an increasing worldwide attention to involving and more directly engaging patients in a variety of health system domains. So importantly, this shift from patients as research subjects or those being consulted to more active participants, collaborators, and partners. And this is really the underpinning for patient-oriented research. Next slide, please. So I just want to talk very, very briefly about major investments in this different way of doing research. So while Canada is certainly has this initiative within the SPORE commitments, this is something that has been in place in other jurisdictions for much longer than in Canada. So I would usually characterize the UK as kind of the first out of the block in terms of having this reorientation of clinical and health systems research to the priorities of patients. Early 2000s, the UK started working in this arena quite diligently, followed by the US, the Patient Centered Outcomes Research Institute, around 2008 to 2010, followed by Canada with the strategy for patient-oriented research about 5 to 7 years ago. Next slide, please. And what do we mean by patient-oriented research within the Canadian context? So ultimately, the aim is to achieve impacts or benefits that matter most to patients, right? Whether that be improved health or increased access to the healthcare system, this idea of the right treatment at the right time, but also importantly, bringing patients into the center of our research activities, being active and informed partners in their healthcare, but in order to do that also at the earliest stages in the health research arena as well. So a variety of ways for doing that, but really the focus on collaborations, new collaborations that will generate and translate knowledge to achieve very broad system-wide impacts that are of priority to patients and communities. Next slide, please. More specifically, definitions that SPORE actually has for patient-oriented research and patient engagement. So again, these two concepts really intertwine quite closely. The idea of a continuum of research that engages patients as partners, identifies patient priorities, and puts them at the focal point for activities. And then by doing that, there is a lot of focus on engaging patients meaningfully and actively through collaboration, and at all levels in the research arena. Next slide, please. So often, as for people who are newer to this area of work, who are thinking about how do I do this? How do I engage? How do I partner with patients, community members? How do I actually, operationalize this? I like to talk about key concepts that really are fairly simple to think about. Who are we engaging or partnering with? What do we mean by this idea of engagement and partnership? And what are our goals? So the idea of different, we might be thinking about different people in different roles for different purposes. Next slide, please. So to start with, on the who to engage and partner with, again, a variety of different individuals or groups of people we might be considering. We often think about those with with knowledge, who have experiential knowledge, who bring experience with particular conditions, illnesses, or with aspects of care. These are people who we want to bring into our research activities because they provide a particularly important set of perspectives that we may not be able to bring in from any other members of the team. So we think about patients, family members, caregivers in that group. But there's another group we often may be thinking about, more general population community groups who have a shared identity. So in the case of the Mira Collaborative, we're thinking about older adults who may be individual citizens, who may be part of groups in their communities. They may share geographies, stages of life, vulnerabilities, or limitations. So they bring maybe not as much that direct experience with the health system, although most of us do, but it's more their shared identity that is the experience we're looking to draw from. And then finally, I think it's important to distinguish between individuals who we may bring into our research activities from organized groups or organized interest in a particular area. So someone may be an individual suffering from a particular condition or who's at a particular life stage. That may be different from the community group or the organization that they're affiliated with. And you may be interested in both of these things, but I think it's important to consider them differently. Next slide, please. When we look at the, oh, sorry, you just went ahead. Yeah. So when we look at the idea of how, right, what are we talking about when we're thinking about involvement, engagement, partnership, co-design, lots of different terms that are put out there with different meanings. And I think to some extent, this actually reflects the evolution of the field. So early days of consultation, more traditional ways of involving people, more passive, kind of more, we will ask you to provide your input and perspectives when we want them. We're now moving much more towards a kind of more equal partnerships, more equal power sharing, more co-designing and partnership roles and models. So you'll see, I think, if you are newer to this field, when you're starting to read literature and documents and just work your way through this, you'll probably find that there's a myriad of different terms and kind of labels being used. Important to think about this idea of, how do you want to bring your community research partners, your patient partners into your work, right? Is it more in that consultative phase, which is perfectly fine, depending on what your goals are, or are you looking to bring them in more maybe as a true partner at all stages of the research? Next slide, please. And I think most importantly, and sometimes this is lost a little bit in our kind of zeal to just get out there and start engaging and partnering, is to really think carefully about the goals, right? What are we trying to achieve? Often, it's higher in the research world, it's higher quality, more responsive research that's responsive to the needs, to the priorities of our patients, our community members. But sometimes it's process-driven goals as well. We actually want to do our work more in a more conclusive way, more legitimate way, and perhaps even in a more accountable way. Developmental goals or capacity-driven goals are also really important to consider. Often this kind of work increases the capacity of all of us, our research partners, as well as us as researchers, and should also be considered in the mix as we're thinking about the who and the how. And then finally, sometimes you'll have people thinking and coming to a research project or an initiative with this idea of, well, this is, I have a right to do this. I'm a taxpayer, I'm a community member, we actually have an obligation to engage our community partners or our patient partners because it's the right thing to do. It's something that we ethically feel a responsibility for. Next slide, please. So just a couple of other points before we move on to the other speakers, and we'll have two other segments that are going to follow this one. When we're thinking about trying to embed high quality engagement practices into our research, few key areas to work through, thinking about the scope and level of engagement and partnership, this issue of the who, how are we going to be looking at recruitment and selecting or bringing identifying appropriate partners to bring onto our research teams. Importantly, clarifying and negotiating these roles at a very, very early stage, and thinking about how we orient and support our community research partners, as well as the research members of the team too. Next slide, please. So want to say a couple of words about the Mira Collaborative for Health and Aging. This is a member of a network of research centers across Ontario that supports patient-oriented research. The particular focus of this research group is the focus on advancing the science of patient engagement and on methods and tools to support patient-oriented research that has a particular focus on aging, and it is the only center with this very specific focus. Next slide, please. Areas of expertise that this group brings, obviously in the area of patient and caregiver engagement, also co-design work that you'll hear a little bit more about, around implementation, evaluation, and scale up as well, transitional care, a number of different areas that where the team has particular expertise. Obviously, the focus today will be on the patient and caregiver engagement piece. Next slide, please. Our activities are organized around goal groups. So again, you'll see some clear mapping between the areas of activity and the expertise and these goal groups. So obviously the patient engagement goal group is a very active one, given the particular focus that we have in this area within the collaborative. Next slide, please. And the last slide that I wanted to share with you, which kind of sets us up for the next part of the webinar, is a guidance document that we released earlier this year, focusing on guidance for partnering principles and strategies. And this is, I think, a great example of a resource that's been produced by the collaborative that very much in that co-design realm, where we had Rebecca and I, as well as Penelope, who you'll be hearing from in a moment, and a number of other members of the collaborative actually work together to develop a principles and strategies guide that is actually guiding the work that we do within the collaborative, but we hope will be also very relevant to many other research groups. And I don't know whether Jennifer or someone else might be able to put the link to that document in the chat perhaps, but certainly if you go onto the Mira Collaborative website, you can find it quite easily. I think that's my last slide. Maybe we'll go to the next one to make sure. Yes, so I'm going to turn it over now to Penelope and Maggie.
Thanks, Julia. So for those of you, I noticed in the poll we had 18 people who have none or some experience with patient engagement. So I feel like this section can maybe help talk a little bit about what we actually mean when we say engagement, or at least what it meant for Penelope and ourselves when we were working in the collaborative. So I'm going to ask Penelope some of these questions. And as we get down the list, we'll kind of ask you guys your thoughts as well. So Penelope, good morning. Hey. You're muted right now. Perfect. So first, I just wanted to ask you to tell us a little bit about your background. Tell us about your experiences. What perspectives do you bring to your role as a research partner? Who do you feel you represent in your role?
Well, background is kind of checkered. I've worked in a number of different fields throughout my life, but in terms of, the healthcare system, I mean, at various times in my life, I have been a patient. I've helped family members negotiate and maneuver their way through. I've done a limited amount of caregiving for several older adults, but I think my role right now is mainly as a citizen and simply an older adult, bringing just perspectives from all of those areas at various times.
That's great. Well, and can you tell us a little bit about what projects and activities you've been involved in through your work with the collaborative?
Well, actually, I notice here it says, how did you get started? I got started before the collaborative, saw an advertisement in, I think it was in the newspaper, for a study that was looking for some input from older adults in the city on transitions from hospital to home. It sounded intriguing, so I'd never sort of realized or seen a situation where they were going to do research and not actually have subjects as the partners. So I decided I would go. And I got involved with the CAS study and then was invited to join the collaborative. And since then, well, I was involved with the development of that partnering principles document. And depending on, and a number of other studies. So depending on the study that particular thing, I've been involved with developing study plans and designs, a little bit of data analysis on occasion, knowledge translation. I've also recruited citizen and patient partners for some studies. I've been asked to vet baseline assessment forms. I've reviewed and commented on papers arising from studies. So I've done a variety of different things.
Yeah, sounds like you've done something at every stage of the research cycle.
Yes, which amazes me.
Yeah, you have lots of experience. Can you tell us a little bit about what have you found challenging about being a research partner?
I think this is going to sound funny, but I think the most challenging thing, especially when you first start out, is jargon. And, you know, I mean, adults don't like to look like they don't know things. It's just a matter of, you know, the way people are. And so to be in a room with a lot of people who are throwing a whole series of initials around that you don't know what they mean can be quite intimidating. So, I mean, that to me is the most challenging part. I mean, once you get over that, I have found it all to be really quite easy to be a partner.
Yeah, well, and as somebody, I think if you get into any new situation, the jargon can be hard. I remember making little notes in my notebook about all the different acronyms that I didn't understand and trying to go figure them out.
Right. You know, I do the same thing. And then sometimes, like with the collaborative itself, that doesn't meet very often, then it's like it's been months since you've heard that particular acronym and you sort of don't want to ask again because you know it's been explained. So yeah, that can be a little intimidating, but you get over it.
Well, and thank you, Jennifer, Jennifer kind of put a variation of that question in the chat as well, which hopefully we can pick up on it at some point, but I want to keep going to ask Penelope some more questions, kind of like the reciprocal of what's frustrating, but what keeps you involved in the collaborative and keeps you involved as a research partner?
I'm a very curious person, and I like to, I'm really excited by knowing what some of these studies are that are going on. I really enjoy working with younger people. I mean, almost everybody is younger than me, younger people who are so enthused and excited about the work they're doing. And that alone is enough to keep me wanting to come back. Yes.
Well, and kind of in follow-up, when do you feel the most engaged as a research partner?
Believe it or not, in the meetings that we have and in the discussions that we have with the other people, the researchers, other stakeholders. Yeah, it's really interesting, and I love the idea that there's such a variety of people in some of these studies that you're sort of bouncing ideas off and they generate new ideas and you get to think about things in ways you never thought about before.
I definitely agree. All of these big multidisciplinary teams, there's lots of people to learn from.
Yes.
Like as a trainee, I find that as well. And finally, tell us a little bit about, some advice you have for other people who are thinking about getting involved, either as a research partner or starting to involve patients or community members in the research.
Well, in terms of people who might want to get involved as a research partner, I would just say, just do it. I mean, even if you're not, when I went to the very first organizing meeting of the CAST study, I wasn't sure that I belonged there or that this was something that was appropriate for me. And so you just sort of take a chance and go. And again, for partners, you just, I mean, it can take as much, you can get as involved as you want. You don't have to do you don't have to do hours and hours and hours of work a week. If I mean, one meeting every 3 months was what the CAST study was. And, and that was, and the occasional email in between. So,
but yeah, anything to tell researchers thinking kind of new to the engaging patient partners, what would you recommend for them? What's your advice for them?
Oh, gee. That's a tough one. Yeah, I guess, again, sort of being careful about jargon is really important. And having some continuity. I mean, if you're going to be talking to people or trying to recruit them, having sort of one person who does it, and perhaps might have to contact them more than one time, but having a person that the older adult can get to know or feel they know, so they don't feel like they're, say, going into their first meeting and they're going to have all these total strangers there.
Yeah, I could see that for sure. And thank you, Maureen, for saying what the CAST acronym as well. I feel like we have one patient partner who will stop anytime an acronym comes up, and he'll interrupt us and say, and what does that one mean? And what does that one mean? But it's a good way to keep us on our toes. Anyways, I'm going to pass it over to Rebecca to talk a little bit about a review we did. Thanks, Penelope, for answering the question.
You're welcome.
And thanks, Maggie and Penelope, for that great discussion. We've added to the chat for people to continue to build. We'd like to hear from people in the audience about, for those of you who, we have a few people who have been research partners as citizens, as patients, as caregivers. So we'd love to hear your perspective. And for those who are perhaps on the research side, also some questions for you as you think about partnering and what strengthens your commitment to partnering, and what aspects do you find challenging, because there are challenges that we face. And so, we'd love to hear a little bit more. And thanks, Carly. We can always count on you to chime in with us. So that's terrific. I'm just going to ask Jennifer if you can go to the next slide, and we'll continue to see those comments and we'll revisit them. So as Maggie said, I have the opportunity to present the findings of an evidence synthesis that we did. So our working group, so this was a collective effort, and we conducted a systematic review to look at what available evidence there was, what studies had been published, to tell us about how older adult engagement had been implemented and evaluated in existing research. So if we can go to the next slide, please. So we wanted to understand better how it had been done, and with what impacts in particular, because we knew, we had a sense from the literature that we had seen that there was a little more around, or there was more evolving evidence around implementation and less around impacts, but we wanted to do it in a systematic way to be able to really understand that body of evidence and hopefully advance the science. So if we can go to the next slide, please. So I'm not going to go into the nuts and bolts of the methods. We followed a pretty traditional systematic review approach. So what we ended up with were 33 included studies based on international literature. I'm going to tell you a little bit, oh goodness, sorry. I'm going to tell you a little bit about the patient, the partner characteristics, and I may say patient, in many cases it was patient partnered research, but also there was a lot of community-based research where people were citizens and invested in particular issues, but not necessarily using that lens of patient-oriented research. So they had diverse experiences. Some of the partners had experience with dementia, with caregiving, with self-harm. There were a variety of community representatives, as I said. Some considered themselves consumers. Some were from ethnic minorities. I'm going to just... nursing home residents. So there were a small number of studies around nursing homes, residents of seniors apartment buildings, and Indigenous elders. And really thinking back to what Julia said about some of those institutions that have supported patient-oriented research internationally, not surprisingly, we saw a lot of literature coming out of the UK, some from the United States, a couple from Australia, and a couple from Canada. We can go to the next slide, please. So the characteristics of included studies, if we look at it, many of the studies were qualitative, some participatory action research, some community-based participatory research. So as Julia said, if we went back further in time, these are long established methods. There's been greater emphasis and greater investment, and we weren't necessarily surprised by the study designs. There were a few that were mixed methods, a couple that were evaluation, but really the bulk was in a qualitative umbrella. And the settings in which they took place, most of the studies took place in the community and small, with a much smaller number focused on particular population subgroups or settings. Next slide, please. So, and we also wanted to look at, I should say, for this study, the way that we looked at the information that was gathered in the studies, we actually looked at the GRIP2 reporting checklist, which is a reporting tool to look at patient and public involvement in research and lays out a variety of parameters or constructs that we were looking at. And one of these areas was looking at the theoretical foundations and the conceptual foundations for the research. So the most common frameworks used were participatory action research and community-based participatory research. One reported on development of a model of involvement across a cohort of sub-studies. So this was the CARE 75+ model. One was translating, using a previous engagement framework and applying it to a network, a geriatric network, and quite a number did not report on any theoretical or conceptual underpinnings. Next slide, please. So what we saw was engagement across the phases. It was really common. Most studies reported on involvement in execution and translation phases. There was far less who reported on that very beginning preparatory phases. We know there are challenges with that at times. Sometimes people aren't engaged until after the grant is in place. Sometimes people are engaged in a small way in the preparatory phases. It's as the grant is going in. We've heard this from a variety of partners where sometimes there are those last minute requests. And I think there's an opportunity to do a more fulsome, and probably as we look at where the literature goes in the next few years, we're going to see, based on some of the existing investments, more upstream involvement, people who are really involved in developing the priorities for the research questions, and helping to inform the research plan. And I shouldn't sort of paint a bleak picture. We did see some studies that really reported well about engagement throughout all research phases. So if we can go to the next slide, please. So I want to talk a little bit about how people were engaged, some of the examples. So in the preparatory phase, as I said, some people were involved in some partners were involved in identifying research questions, the project plan, the topic for the study, what the focus should be. In thinking about study design, it was looking at informing, this would be post-grant when grants were funded, then informing the more specific research plans, the methods, developing tools such as data collection tools, models as well, so informing models of care. There were a couple of examples where the partners were involved in making sure that any materials associated with the study reflected cultural relevance, that they made sense for the communities in which the research was being conducted. In terms of recruitment, people were involved in the procedures, so what the plan was for recruitment, identifying recruitment strategies, and in other examples, people were also involved in directly recruiting or explaining the research to people so that they would consider getting involved. In terms of data collection, people may have been involved in conducting the data collection. They may have facilitated focus groups or facilitated discussions. They may have contributed to priority setting exercises and supporting the data collection overall. In terms of data analysis, that may have looked like member checking, helping to identify themes in the qualitative research, making sense, interpreting the findings, those kinds of activities. And in terms of knowledge translation, it could be providing feedback on written materials, presentations. It may have also, with presentations, looked like co-presenting with people. We're seeing more of that, encouraged and embraced, and I think for any of us who've been involved in any kind of knowledge sharing in partnership with patient or citizen perspectives, those are things that people really tune into and attend to, and so I think there's a lot of value there. And promoting the uptake of the research. So sometimes identifying who are the key audiences that need to hear these messages and what are the messages for those particular audiences. So we saw that throughout the literature, the body of literature that we looked at. Next slide, please. So while 2/3 of the study reported on impacts, few of them measured the impact. So there was a lot of qualitative narrative reporting of the impacts, and those impacts were, sort of varied widely. Sometimes it was talking about the impacts on partners. Less frequently, there were the impacts on researchers themselves or other partners that were involved, other stakeholder groups that were involved in the research. There were impacts on how the research was implemented or planned, and there were impacts on the study implementation, how it was conducted, and the outcomes. And in some cases, there were impacts that were reported on the participants of the study. So if we think about the partners that informed ultimately the impacts on participants. Next slide, please. So some of the recommendations from this review that we found, so these are some recommendations that there are opportunities to enhance the reporting of patient and public involvement in research. It was highly variable. Now, something that's important to note is that those reporting guidelines were only published and shared widely at a certain time point within a broader date range that we looked at. So it's not surprising that when we go back retrospectively, that perhaps there was less methodological reporting of how engagement was conducted. And I should also say the GRIP2 tool, for people who are not familiar with it, has a long form for studies that where the major focus is on the engagement, and a short form, so less constructs that you're looking at for studies that where it's a secondary emphasis of the study. And although you might think, okay, so that means there's less reporting in those secondary emphasis studies, but some of them are really well reported, and some had it as their primary emphasis. And there were opportunities for more rigorous reporting of how they engaged people and with what impact. So we do think that tools such as the GRIP2 or other tools can help researchers design studies that integrate impact measurement metrics. So as I said, there was very little reporting of impact measurement. I know that there's work happening to look at how do we best measure the impact of engagement. And so I think there's some really real opportunities for the field to move forward on this front, and that the science of evaluating the impact of engagement is really emerging. We could go to the next slide, please. So ultimately, for those that did report impacts, the engagement process, the process of engaging older adults in research led to creation of new partnerships in some cases, continued collaborations on new projects. So similar to what Penelope said, where she got involved in one study and then it led to another collaboration and then she's become involved in other studies. This was the case for other people where engagement went well, where people felt connected with the research and thought that the process, they felt like their input was heard. Then it led to continued collaborations on new projects. And some older adult partners reported that their involvement in research actually helped them with better self-management of their care and being able to navigate their care. Next slide, please. So I'm going to turn it over to Maggie and Penelope, and they're going to talk. So based on this research, so we have a systematic review, we have a draft underway, but we also created a research brief based on this study. And Maggie and Penelope are going to talk about their experiences creating and getting input into this research brief.
Yeah, so thanks, Rebecca. Basically, what we did, there was an opportunity to share some findings from this work with local decision makers. And so we saw an opportunity there to share some results of our research on the implementation and impact of engaged approaches with older people. And then also, given my past experience as a policy analyst, I met with some of the patient partners to just talk about, what is the function of a research brief? Why do you share a research brief? What does it include? What does it not include? How is it written? How is it written differently than other things that you've seen in research? And basically we got together as a group, but in advance of getting together as a group, we shared this research brief. I shared some of those discussion questions that I just asked. And then we talked about, what did you notice about the review or about the research brief? Did it make sense to you? Where did it not make sense to you? We also talked about, what's the most important thing for an older adult living in the community to know about that piece of research. And then I think that we got together, we had some discussion, we talked a little bit about, where maybe the brief, there was one spot in particular where they thought that our language, we were trying to get at that idea that we excluded studies where the older people were research participants. And some people in the group said, well, then who did your study include? But we're trying to get at that idea that we're really looking at studies where the older people were research partners, not just research subjects. So that's a tricky, the semantics are challenging for all of us. And so I think that feedback was really important for us to clearly express, what studies were included in this review, and what types of older people were included in the review as well. And yeah, Penelope, do you have anything to add about contributing to the research brief, or?
No, but again, that was a one where with a group of people talking about something, they generate ideas and bounce ideas off each other, which I think helps clarify things for everybody. Because all of a sudden you realize that you thought you understood that, but really you didn't when you start, getting the answers. So, just in terms of doing these things as groups is really valuable.
And something that I would add, I'm just going to jump in. This is an example where we asked our partners about the extent to which they wanted to be involved in this. And knowing that not everyone wants to do a deep dive, people are welcome to get involved to whatever extent. But I think it's probably fair to say that there weren't any partners that really wanted to do the reading of the article specifically and to be extracting the data or doing any of the steps of the sort of implementation steps of the review, that it was really more of interest to help with interpreting and making sense of the results. We did have some input into the plan to conduct the systematic review, but I think it's important to create opportunities for people to choose the kinds of activities that they want to participate in. So that's maybe important if I think about what I presented along the review and what we found across studies, we can't necessarily say that that was misaligned with what people were interested in because we don't have that information. We can just say that they didn't report on involvement at that stages. But if I think about this review process, there were some of the stages where there wasn't a lot of involvement, but more involvement towards the end and thinking about making sense of the messages and the so what.
Mm-hmm.
Good. But yeah, that's all we have to say about the brief, I believe.
Great. Well, thank you, Rebecca, Julia, Maggie, Penelope, for just a great presentation. Very informative, and I'm super excited to hear all the great work that's been happening. I just want to acknowledge, the funders for the Mira Collaborative, which includes the, again, some acronyms for everybody, OSU Score Support Unit, the Strategy for Patient-Oriented Research Canada as well, spearheaded by the Canadian Institutes of Health Research, along with the Government of Ontario. And at this point, I'd like to open it up for questions from the attendees. Feel free to unmute yourself or type in the chat box. We'll monitor the chat box, and I'm going to stop sharing my screen so I can navigate the chat box. But yeah, I just open it up for discussion, questions.
There is one question already in there. You're going, okay, good.
Yeah. There was a question from John Riley from the Ontario Score Support Unit for the panel. So what are some of the early signs that the partnership is breaking down and what corrective actions can be taken?
I can say just a little something because my postdoc is around evaluating the engagement, and I just had a meeting with some patient partners on a different project, and they said, you shouldn't wait till you're a year in to ask us how it's going. So kind of just that opportunity to ask people, maybe not every meeting, but just check in with people and see how it's going at more regular intervals.
Mm-hmm.
And I think some of the things that can happen is that in meetings, for example, if it's done through a meeting, that there may be insufficient time to contribute. There sometimes, depending on how the conversation has gone and how comfortable the partners are, you may be able to get a sense of either verbal or nonverbal discomfort with the situation that people express. If there are times when people aren't contributing, are asked to contribute, but if it's an ongoing, I mean, not everybody's going to want to contribute every time, but if it's an ongoing issue, that's really a signpost to say, maybe we need to connect with this person and see what's happening. Sometimes that may be, there are things that can be modified by the research team to make a more supportive, inclusive environment where everyone feels comfortable contributing. Other times, there are things that are happening in the background in that person's situation that maybe, what shows up sort of in the ways that they interact with the team. So I think it's important to have those, opportunities to connect before or after meetings, to debrief, to connect, to ensure that people felt engaged and had opportunities. I think some of those are early signposts. And I think sometimes people can stop engaging. They stop responding to messages if they're really not feeling engaged. So again, that's a signpost that something might be happening, and especially if it's happening, repeatedly or with more than one partner, it's really important that teams reflect regularly on how, on the environment that's being created.
Mm-hmm. Yeah. I like, for me too, the fact that I feel that if something occurs to me, I may not say anything during a meeting, but after the meeting, so you get an idea, and I feel that I am welcome to contact any of the researchers that have been in the meeting and voice an opinion by email afterwards. That is a valid way to contribute. If I didn't feel I could do that, then yes, I could see that you could eventually become disengaged.
Yeah, Penelope, that's such a great point around having different ways of interacting, that people can contribute in a variety of different ways, and people have different styles of communicating, for sure. Mm-hmm. Julia, I'm going to turn it over to you. I see you've got your hand up.
Yeah, I'm not going to add a lot because I think these points were really, really good ones. I think in my experience, having someone on the team who is kind of looking out for these things, who's got one of their responsibilities is thinking about the ongoing relationships with the community patient partners is really important. It's that supporting infrastructure, right? And I think it's sometimes the thing we don't pay enough attention to or provide tangible resources to in our teams. We kind of have the excitement of bringing patients partners on, and then we kind of assume it'll all just work. And there's actually quite a lot of kind of sustaining that's required of this. I know for longer term projects too, people, all kinds of things happen in people's lives, and they may check out a little bit. Hopefully you don't need the corrective action. Hopefully you put all the supports in place that we've been talking about to make sure that you don't get to that stage. But for me, I think it's often having a couple of people on the team who are just really always looking out for that, because people get really busy and distracted with so many other things that they're doing.
Yeah, I think that's so important, Julia, that you have people who are attending to that. But I think another point is thinking that the whole team needs to be connected to this idea and to value the contributions. And it's true within interdisciplinary research team, valuing different perspectives. It's especially true when we're thinking about partnering with patients, caregivers, members of the public, that we're really, that it's not just a couple of people that think it's a good idea, that people are really embracing the value and the value add through bringing these lived experiences and expertise that we don't necessarily have around, some of these areas of research. They bring their own expertise to the table, and that I think is really important to, that we all have respect for that. Oh my goodness, my phone never rings. I'm so sorry.
Well, I noticed in the chat box, there's a few comments. We have some of our, and there's a few new messages, but from some of our other older adult partners of the collaborative, if we haven't gone through this already, comment was, what keeps me engaged is the learning and that my input is valued. And then there's another question for Dr. Ganann. Did you notice any biases in terms of education or income in the community partners in the systematic analysis? If so, what strategies can researchers use to try to eliminate biases when recruiting community partners for studies going forward?
This is a really great question. Thanks for posing this. I think for sure, when we look across the landscape of patient engagement, I think that there are biases in terms of who often gets engaged, in terms of their educational levels, in terms of their income. I think that as a community in patient-oriented research, more and more people are really attending to this and trying to make specific efforts to make sure a range of perspectives are coming through coming to the table. Even that idea of that coming to the table, there's really a challenge around thinking about, are we inviting people to come to a boardroom table, which can be really intimidating for some people, of course, and thinking about different ways of engaging. And I think, it's not always in a meeting format. Sometimes it's in a smaller group where people feel more comfortable sharing their ideas. So thinking about those different ways of addressing biases. I do want to also let you know, I think it's forthcoming anytime now, but there is some great work that's been done through the Ontario SPORE Support Unit to develop some resources around equity, diversity, and inclusion in patient-oriented research. So I think that will be of interest to, to all of us. I think it's really terrific what's been developed. I had a peek at an earlier draft, so that's really great. And so I'm excited to see that. And I think it'll be of great value to the patient-oriented research community to really look at how we can eliminate those biases to recruiting community partners. I think depending on the study, you're really, going back to some of the things that Julia said at the beginning, when you're thinking about who you're engaging and purposefully looking to engage the people that can shed light or have lived experiences with those particular issues. That's so important. But it's not without investment. I see Maureen has a question in the chat as well about resources needed to support patient engagement. So I think that it is really important that studies are sufficiently funded to provide honorariums for partners, to support their engagement, to provide, ensure that any out-of-pocket costs are addressed, that people aren't facing out-of-pocket costs, and to do our best to really accommodate people in ways that help them or support them to be included in the conversation. So I'll stop there and turn it over to Maggie.
I was just going to add that I think some of what we saw in the review was we didn't see as much engagement in those early phases of research, which is not just, I think it's common, not just in research, engaged research with older people, but in other groups as well, is kind of sometimes people are missing that like pre-grant engagement. And it makes sense, right? Because maybe you're not funded yet to gather your group, but what value your patient partners can provide to your grant, to your research questions, if they are there right from the very beginning. So I think that's maybe like a little hole that resources could help.
And I think a lot of, in the SPORE community, a lot of resources have been developed to help people to know how to engage, where do I start, where do I begin? I think, there's some comments in the chat from Alice and Dubé as well, from Mira, and saying that people may feel that they don't have the right skills to engage with community members. I think it's really important that we engage with people with humility, with appreciation, with genuine interest in getting to know them and build relationships with them. I think sometimes people are only seen as coming to the table as a patient, and we're doing ourselves and our teams a disservice if we don't sort of embrace all of the skills and attributes that people can bring to the discussion. Penelope, do you want to say something?
Yeah, I was just thinking it works both ways, because I think from the the citizen partners perspective, they also can feel that I don't have the background to take part in, to be helping on a research study. And so there's sort of some give and take needs to go both ways on that. I mean, I have talked about what I'm doing with Mira to some of my friends, and their reaction is, I couldn't do that. I don't know enough. I don't have any, I never took science in high school. I can't do this. I have nothing to offer. And so, to try and convince people that they do have something to offer because they've lived a long life and they have had all these experiences.
Mm-hmm. Mm-hmm. And I think it's getting to know people and to understand some of those things, you know, where they might not see that, you know, they have a particular, you know, unique perspective on an issue, but where, you know, we really celebrate those unique characteristics or those unique experiences. And I think sometimes help people to connect the dots between where their experience is and the questions that are being asked and how valuable it is to have their perspective. I also think there are sometimes partners who are newer and say, well, I don't know, there are more experienced partners, I don't know what I have to say. And yet sometimes it's that fresh perspective that is such, you know, adds such value. So it's both the, you know, some of the ongoing experience and the fresh. Julia.
Yeah, I was just going to add a couple of very concrete resources because people were, the theme of resources is coming up in a number of the chat entries, and there are around training, there are resources. So with the previous kind of version of Ontario Sport Support Unit, we're now in a renewal phase, but in the first round, there was a masterclass on patient-oriented research. Masterclass is kind of a funny term, but the idea was to support both researchers, patient partners, clinicians, and policy folks to all coming together. And this was when we were in the time of being able to do things in person, a week-long or several-day, really intensive but incredibly helpful classes on how to do this work, right? So we had plenary groups and breakout groups. And so my understanding is that the materials that supported that have been made available. And I think the Ontario Sport Support Unit website might be a resource. I know John Riley from the support unit is on here. I hope I've got that right. And I believe that there's a plan to actually continue to offer those in the next iteration of OSU. So that's one. I think the other is obviously the guidance document we talked about. And this idea of jargon that Penelope brings up, which is great. CIHR has its own Research 101 document that I have often referred people to. Really nice kind of lay language of just all kinds of terms and things that labels, things you hear about in meetings that are very researchy, that just really explain things very, very nicely. So that might be a helpful resource to some people as well.
And I just want to quickly address, I see that Brenda had a quick question, but also said it's okay if we need to move on. But I think, you know, such an important question. And I'll say Brenda Verkelians from the School of Rehab Science leads also our capacity building and networking partnering goal groups. So some of the other goal groups in the collaborative. So thanks for joining us, Brenda, and for your questions. I think that COVID has presented some particular challenges in terms of people participating, you know, ensuring that we have inclusive environments and thinking about, you know, how people are comfortable engaging. And I think it is important to think about engaging in a variety of ways, that some people are comfortable on phone, some people need a little bit of technology support and orientation, but are often run with it. We've even been able to use some digital sort of brainstorming platforms with some of our partners to be able to do some decision making around activities or priorities. So lots of opportunities. I think people worry that we can't connect that way, but I know in a number of our studies, we've been able to successfully move forward in a digital world, but we've also been very conscious about or concerned with who may be excluded by having to move forward in that way. So definitely looking forward to connecting and seeing people in person as soon as we can.
Well, I'm just looking at the time. I know we only have a minute left. So I want to thank everyone and thank our speakers, Rebecca, Julia, Maggie, and Penelope for your participation in our webinar today. If you have additional questions, you can email us at the collaborative, and perhaps Rebecca, Julia, Maggie also welcome emails of your questions after the webinar. And then we'll also be in touch to share topics of our future webinars. This webinar, the audio recording and slides will be posted to the collaborative website, so feel free to share those through your networks. And again, just thank you for your time and have a great rest of the day. And I see lots of comments coming in terms of a great presentation. So yeah, we'll make sure the speakers receive all these great comments. So thank you, everybody.